Let's dive straight into this explainer, hitting high-yield surgery board review topics with rapid-fire clinical vignettes. We're getting right into the very first scenario.
Question 53. Imagine you've got a 35-year-old guy who had a documented H. pylori-induced duodenal ulcer. He completes the standard 14-day triple therapy, but a year later, he's back. He has the same typical epigastric pain, and a stool antigen test confirms persistent H. pylori colonization. So what is the absolute most appropriate next-line rescue medical eradication strategy here?
The correct answer is D. We have to escalate to a bismuth-based quadruple therapy. See, when a patient fails that initial triple therapy, usually because of clarithromycin resistance, we have to bump them up to a 7 to 14-day regimen. This means combining a PPI, metronidazole, tetracycline, and a bismuth compound. And this actually brings up a really crucial surgical distinction. If medical eradication completely fails and we have to operate, a non-healing gastric ulcer requires local surgical resection just to rule out an underlying malignancy. But a duodenal ulcer, that's driven by acid hypersecretion, so it demands a highly selective vagotomy instead.
Question 54. We have a 45-year-old male presenting with fever, night sweats, some unenforced weight loss, and progressive early satiety. An endoscopy and biopsy confirm a stage 1 low-grade B-cell malt lymphoma. That's mucosa-associated lymphoid tissue, and it's confined entirely to the stomach wall. What is the preferred initial treatment of choice?
Interestingly enough, it's H. pylori eradication therapy. I know, it sounds totally counterintuitive to treat a lymphoma with antibiotics, right? But primary gastric malt lymphoma is heavily linked to the chronic inflammation driven by H. pylori. Fun fact, a normal, healthy stomach literally has no lymphoid tissue to begin with. By eliminating that chronic antigenic stimulus, you can actually see complete regression of the lymphoma in up to 80% of cases during the 12-month endoscopic surveillance window. It's a real game changer.
Question 55. Now we have a 70-year-old male dealing with anorexia, weight loss, and hematemesis. His biopsies show an extensive infiltrative ulcerating mass, and this one is confirmed as a high-grade diffuse large B-cell non-Hodgkin lymphoma. Staging shows node-positive abdominal disease, but no perforation. What is the most appropriate first-line treatment here?
For this one, the answer is D, combined systemic chemotherapy and radiation therapy. You see, unlike those low-grade malt lymphomas we just talked about, a high-grade primary gastric lymphoma won't respond to just clearing out H. pylori. They absolutely require systemic chemo, classically the CHOP regimen, paired up with radiation. And notice that radical gastrectomy is no longer the go-to first-line treatment. Surgery for high-grade lymphoma is now strictly reserved for extreme acute complications. We're talking severe uncontrolled hemorrhage or free perforation.
Question 56. Picture a 32-year-old trauma patient who gets readmitted a few days after an emergency laparotomy. He's got worsening abdominal pain, spiking fevers, and leukocytosis. An urgent CT scan reveals a localized fluid collection tracking specifically inside the right subhepatic space, which we also know as Morrison's pouch. So which viscera is the most likely source of this injury? It's B, the stomach. If the stomach or the duodenum gets injured, those highly acidic contents spill directly into this exact recess. Morrison's pouch is literally the most dependent space of the upper peritoneal cavity when a patient is lying supine. It's bounded anteriorly by the liver and gallbladder and posteriorly by the right kidney and colon. Because of this anatomy, it's an absolutely critical area to check during a fast scan to spot free intraperitoneal fluid in trauma patients. Question 57. We've got a critically ill 82-year-old male admitted with advanced acute empyema of the gallbladder. He's in septic shock with a blood pressure tanking at 85/50, making him an exceptionally high-risk candidate for general anesthesia or any major abdominal surgery. What's the best initial management step to get this infection under control? The correct answer is D, an ultrasound-guided percutaneous transhepatic cholecystomy. Look, putting an elderly, hemodynamically unstable patient into emergency surgery is a massive mortality risk. So placing this tube serves as a crucial, life-saving decompressing bridge. It allows you to immediately drain that purulent bile externally, which stabilizes the patient's hemodynamics. Then, once they're fully optimized weeks later, you can safely plan an interval elective cholecystectomy. Question 58. Think about patients with chronic liver cirrhosis and portal hypertension. What is the most common non-variceal comorbidity that coexists with gastric varices and often complicates your initial endoscopic diagnosis?
The answer is C, peptic ulcer disease. You might instinctively jump straight to varices when you hear cirrhosis, but these patients actually have a significantly higher risk of developing peptic ulcers. In fact, up to 20% of their acute upper GI hemorrhages are coming from an active ulcer, not a varix. A couple of great exam pearls to remember here. Portal hypertension alters gastric microvascular flow, creating this classic mosaic snakeskin-looking mucosa. Also, if you ever find isolated gastric varices with zero esophageal involvement, you should immediately suspect splenic vein thrombosis.
Question 59. A 40-year-old completely asymptomatic female is getting a routine ultrasound, and they incidentally find a well-circumscribed 1.3 by 2.5 centimeter smooth polypoid mass sitting right in her gastric fundus. What is the next step in managing this?
The answer is E, an endoscopic flexible snare excision. Here's the rule of thumb. Any epithelial gastric polyp larger than 1 centimeter in diameter absolutely mandates complete excision and histological characterization. We have to completely eliminate the risk of long-term malignant transformation. Since this one is a broad-based sessile polyp, an advanced endoscopist will typically use submucosal saline lifting. They literally inject saline right under the polyp to safely lift it away from the muscularis propria before taking it out. Question 60. A 40-year-old female comes in with a 6-month history of progressive abdominal distension. The examining surgeon palpates a smooth umbilical mass. Now, this mass demonstrates free left-to-right mobility across the abdomen, but absolutely zero vertical mobility. What is the most likely diagnosis? It's B, a mesenteric cyst, that very specific horizontal-only mobility. That's the pathognomonic Toulouse sign, and it's the key to differentiating this from other cystic masses. A mesenteric cyst is embedded right within the leaves of the small bowel mesentery, which runs diagonally from L2 down to the right sacroiliac joint. Because of that, it can only move perpendicular to its root. Just compare that to a benign omental cyst, which floats in the greater omentum and moves freely in all directions, or an ovarian cyst, which is just stuck inferiorly down in the pelvis.
Question 61. A 59-year-old male presents with a 6-month history of dyspepsia, unenforced weight loss, and recently the passage of black, tarry stools, otherwise known as melena. What is the mandatory next step in his management? The answer is E, immediate esophagogastroduodenoscopy, or EGD. Now, if you have uncomplicated dyspepsia in a younger patient, you'd usually just do a standard empirical test and treat for each pylori. But the presence of these red flag alarm features, that completely throws the normal protocol out the window. If a patient is over 50, has unexplained weight loss, or shows any evidence of bleeding like melena, you absolutely must do an endoscopy to rule out a gastric or esophageal malignancy. You just can't risk missing it.
Question 62. A 45-year-old female undergoes an elective laparoscopic cholecystectomy. Upon gross pathological inspection, the excised gallbladder has this really striking strawberry gallbladder appearance. Which statement correctly characterizes what's going on here?
The correct answer is C, which defines cholesterolsosis. This is a completely benign condition where you get abnormal deposition of cholesterol crystals and triglycerides right inside the lamina propria macrophages of the gallbladder mucosa. So you get these little yellow lipid deposits scattered all over the pink mucosa, making it look exactly like the seeds on a strawberry. The big takeaway here is that this has zero malignant potential. However, on a high-res ultrasound, these fixed lipid deposits can very easily mimic small adenomatous polyps, so keep that in mind.
Question 63. A 40-year-old female presents to the surgical ED with a high-grade fever, chills, severe right upper quadrant guarding, and a palpable, highly tender globular mass. What is her most likely diagnosis?
It's D, an empyema of the gallbladder, or suppurative cholecystitis. A gallstone persistently blocks the cystic duct, causing bile stasis. That stagnant bile then undergoes secondary bacterial contamination, and the entire lumen fills up with frank pus. Now, you need to be acutely aware of something called the diabetic autonomic mask. If this was a diabetic patient, their peripheral and autonomic neuropathy could actually blunt these classic visceral pain pathways. That leads to a dangerously silent, vague presentation that can easily progress right to a perforation before you even see marked physical findings.
Question 65. What is the most common iatrogenic cause of a major common bile duct transection or injury?
The answer is B, laparoscopic cholecystectomy. This usually happens when the common bile duct is accidentally misidentified as the cystic duct and then clipped. to prevent this devastating complication, surgeons must strictly adhere to the critical view of safety. So as we wrap up this explainer, ask yourself, when you are in the OR, are you systematically clearing the hepatocystic triangle of all fat and fibrous tissue to definitively identify exactly two structures, the cystic duct and the cystic artery, every single time? It's a critical, potentially life-saving habit to build into your practice.